Prologue, Nizara, 1979. When Roy Barrett and I touched down in Nizara, it was close to dusk. Night brought with it no relief. The heat was every bit as brutal as it had been in Juba before our plane took off. The humidity of Sudan sucked every drop of sweat out of us. There was simply no way to cool down. Because the pilots could only fly by sight, they were compelled to stay overnight at the same government rest house where my colleague and I were being lodged. They weren't pleased. The thought of spending any time in an area rife with a lethal infection had them unnerved. But there was nothing else they could do, not if they wanted to make it back to Khartoum in one piece. The delay worked in my favor, providing me with a terrific opportunity. This way they'd be able to take something back to Khartoum for me and get it to the U.S. Embassy, which could then ship it to the States. They wouldn't know what was in the package I'd be giving them. If they did, they'd certainly refuse it, for, if our hunch was correct, the package would contain the very thing that they were most anxious to flee, the Ebola virus. Not that they would be in any danger of infection. I knew how to pack specimens carefully so that the air crew wouldn't run the risk of exposure. When I told them that I wanted them to take a package back to Khartoum, they were actually quite agreeable. We needed to get samples back to our lab at the Centers for Disease Control in Atlanta as soon as possible so that we could determine the cause of the outbreak. Today, there are other faster and more sensitive tests, some of which can even be done in the field, but in 1979, the only way to know for certain that a disease was in fact Ebola was to identify specific antibodies or to isolate the virus in cultured cells or tissues. Clinical observation alone wasn't sufficient. In this part of the world, where the average lifespan is less than 50 years, infectious diseases are ubiquitous. Many different infections can look like Ebola in the early stages of the illness. Symptoms like high fever, headache, abdominal pains, and sore throat can signal the onset of the flu as well as Ebola. Telltale signs of bleeding suggest Ebola, but, even then, establishing a correct diagnosis may be tricky. And if what we had turned out to be Ebola, there was another question that needed to be answered. Was it the same strain as in 1976, or was it yet another virus, something that we'd never seen before? We decided to examine the patients at the makeshift hospital in Yambio, a town located not far from Nizara, the same night. As soon as Roy and I could deposit our gear, we gathered together all the instruments we would need to draw serum samples from the patients. Obtaining these samples was only half the battle. We had to preserve them, too. First, we would have to take the blood from the patients, then separate the red blood cells from the yellow serum containing the virus, freeze the serum samples in dry ice we brought with us all the way from Khartoum, and finally package them for shipping. When we arrived at the hospital, all we found was a dimly lit mud-walled building with a thatched roof. There were no windows. A few people were clustered outside the entrance, families of the patients dying inside. Their faces were filled with anguish. Roy and I donned protective suits, which looked nothing so much as U.S. Air Force jumpsuits, only these jumpsuits were made out of white plastic-coated paper. Then we put on our full-face respirators. Not only were these unbearably hot and cumbersome to wear, they invariably had the effect of scaring the patients to death. That is, if the Ebola didn't kill them first. Inside the hut, we were greeted by a truly macabre spectacle. In the uncertain light of two small kerosene lanterns, we could make out about a dozen patients, all adults, lying on mats on the bare earth. Some of them were thrashing about delirious in a futile attempt to escape the disease consuming their bodies. Others lay still, the rattle in their throats an unmistakable sign that they would soon be dead. The terrible heat of the equatorial night held us in a merciless grip. The jumpsuits and the respirators made it worse. Sweat was pouring off us. We could barely breathe. To examine each patient, it was necessary for me to get down on my knees, lantern in hand, while Roy helped organize the blood samples as soon as I collected them. He had never worked in a developing country before, much less witnessed the devastation of Ebola, so this must have been a big shock for him. Frank bleeding is not common in the early stages of Ebola, but minor manifestations, such as bleeding in the eye, are often present. I had to look into the whites of their eyes and inspect the interior of the nose and gums for evidence of bleeding. Petechae, which are tiny points of bleeding into the skin, are a significant clue, but they're hard to see in dark-skinned Africans, even under optimal conditions. By the dismal light of a kerosene lantern, they were impossible to detect, except in the whites of the eyes or the roof of the mouth and throat. A fine rash is also associated with Ebola in some cases, but again, I could scarcely expect to see it in such bad light. Yet, one glimpse at these people's throats provided me with convincing evidence. 2 or 3 days into the infection, following an incubation period of 5 days, Ebola can produce a throat so swollen and painful that a victim of the disease can't even swallow his own saliva. When you peer down such a throat, you see what could be mistaken for raw hamburger. A yellowish pus-like substance may ooze from the tonsils. Bleeding from the rectum is another sign of Ebola, but unless the bleeding is significant, which often it is not, you have difficulty being sure. Either you ask a family member or else you have to get a stool sample and test it for blood, but for logistical as well as cultural reasons, this sort of test is often difficult to do. It was like practicing medicine the way it had been done in the Dark Ages. We had no X-ray machines, no blood counts, no blood cultures, no diagnostic capacity except for our own training and experience. Nevertheless, we pressed on, patient by patient. Each patient presented a different challenge. 3 of them were delirious and uncooperative. In order to examine them, I had to find either a nurse or a family member to help me and to hold their arm while I took some blood. When we were done, I was fairly certain that at least 7 patients had Ebola. About the others, I was less convinced, but it was our obligation to separate the ones we were sure were infected from the ones who might be suffering from other ailments, and then try to treat them as best we could. At the end of about 3 hours, we were done. It was nearly 11 p.m. I'd been up for some 20 hours, and I was exhausted. But my job wasn't over. I still needed to separate the sera from the red blood cells. The lab technicians at the CDC would be upset, and rightly so, if they received samples of serum filled with lysed red blood cells, which would interfere with the accuracy of their tests. Without electricity, I had to resort to improvisation. I had had enough foresight to bring along an antiquated hand-cranked centrifuge, but because it contained only 2 buckets, it could only handle 2 samples at a time. I had 13 to separate. Since I had to spin each pair of tubes for about 10 minutes to get a reasonable separation, it would take me at least a solid hour of cranking to get the sera separated. Then I would have to separate each one into aliquots, label them, and pack them on dry ice. It didn't take long for me to discover, in my dilapidated state, I was simply incapable of cranking the centrifuge for 10 minutes without taking a break. I was working in a room equipped with a small, shaky wooden table. I had to work alone, certainly. I couldn't let anyone else in with me. A tube might accidentally break, or else in my fatigue I might splash myself. Why subject anyone else to the risk? I was wearing a simple surgical mask. It was just too hot to use that respirator, and my protective paper suit. Since I wear glasses, I didn't see any need to put on goggles. In spite of my exhaustion, I was careful as I could be, but that didn't mean that I was safe. I might have infected myself at almost any time without realizing it. I wouldn't know for sure until the incubation period passed, after which coming down with a fever and the racking body pains would characterize early Ebola infection. It took me nearly 5 hours to finish all 13 serum specimens. It was now almost 5 in the morning, and I could hear the first sunbirds in the acacia trees above the tall grass beginning to chirp to the first light. I was beyond exhaustion, and the beautiful African dawn seemed slightly out of focus in the early mists. The rest house where I tried to get some sleep consisted of a few rooms with sagging wire-frame beds supporting thin cotton mattresses. There were no sheets. Though it was cooler here than it had been in the hospital, the suffocating heat was still oppressive. Getting to sleep was difficult, and it didn't last long. Somehow I managed to get up again around 7 a.m. to deliver my precious box with the arduously separated sera to the pilots before they could take off to Khartoum. And this was only the prelude. Our formal investigation began the next day. Our job was clear. We had to determine the extent of the epidemic, identify all the cases, and isolate the victims so that they couldn't transmit the infection to others. Over the next few days and weeks, we conducted an intensive search for people stricken with Ebola. At the same time, we set up a small lab to test for antibodies. This way we wouldn't have to wait for test results to come back from Atlanta. 2 nights after our arrival in town, I was back in the makeshift hospital examining a suspected Ebola patient. On this occasion, I decided to forego the respirator, which was simply too uncomfortable. The patient was an elderly woman who had been brought in from an area where there had been a confirmed case of Ebola. She was delirious and spiking a high fever. Just before she was admitted, we were told she'd suffered a seizure. Ebola patients sometimes have seizures, particularly at the end stage of the disease. Although I failed to detect any signs of bleeding, there was no question she was very ill. I knelt down to take the blood sample. Because she was thrashing around, I would have ordinarily had somebody hold her arm, but she was so old and frail. I thought that I could handle her by myself. Gripping her left arm tightly, I prepared to place a needle in her vein. I inserted the needle and then began to pull back the syringe to ensure I was in the vein. Suddenly, she gave a violent lurch, displaying far more strength than I had thought possible from such an ill old lady. The unexpected motion caused the needle to slip. My glove was punctured. The next thing I knew, there was a small drop of blood on my glove. My blood. A moment later, I registered the sting of the needle. I saw now that it had broken the skin at the base of my thumbnail. I swore under my breath. How could I have been so careless? I had bled over 300 victims of Lassa fever and never come close to pricking myself. My first instinct was to pull off my glove and cry out, but what good would that have done? Though I rinsed off the glove with disinfectant, I knew the damage had been done, so the only thing I could do was finish bleeding the woman and continue with my work. I can't say that I was calm, but I wasn't in a panic either. Still, I had a nauseating feeling. I knew, more than most people, that when you get stuck by a potentially contaminated needle in the midst of a deadly epidemic, like the one I had investigated in Zaire, the odds for survival aren't very good. Actually, I'd have to say that the fatality rate was about 100%. Of course, now I was in the Sudan. It was possible this particular strain of the virus might be less virulent, though the data was unclear. I also knew that a British researcher named Geoff Platt had stuck himself with a needle full of Ebola near Salisbury, England, while injecting mice in the Porton Down hot lab there after the 1976 Zaire epidemic. He became critically ill within days. He pricked his thumb, just as I had, but he hadn't even drawn blood. Like me, he'd applied disinfectant to the wound immediately afterwards. Later, a colleague asked him why he hadn't simply cut his thumb off, so I couldn't take much reassurance from precedent. Nor could I put any hope in a cure. There was no cure. There was no vaccine. There was no treatment. Or almost no treatment. There was one possibility. It might not be worth much, but it was all I had. In 1979, it was thought that convalescent plasma, that is to say, plasma taken from patients who'd recovered from Ebola, might have some therapeutic benefit. But the data from few experiments carried out so far in England, most of which were poorly designed, didn't give much basis for confidence. However, I had taken several units of plasma, which we had collected in 1976 in anticipation of just this kind of situation with me to the Sudan. The plasma wasn't in the best condition, but at least it had been run through a filter so that most of the green gunk that had been collected had been removed. Well, I thought, I'll let Roy administer some of it to me and hope it works. What else could I do? The contingency plans we'd made for this kind of emergency called for me to be shipped out in a plane specially equipped with a field isolator. The plane in question, however, was sitting on a runway in Europe, while the isolator was stored away in the U.S. Naval Medical Research Unit in Cairo. And even if I could get out, I would in effect be shutting down the investigation. No one else on the team had my experience. They couldn't continue on their own. This meant that almost all of our efforts so far would have been for nothing. What would happen if I had stayed on, and what would happen if I had left? I began to play out the different scenarios in my mind. 1. The old woman died. In that event, I was probably incubating Ebola. but I figured at least there would be sufficient time after her death for me to be evacuated. 2. She might have Ebola but survive. If then we tested her blood and found antibodies, we'd have incontrovertible evidence that I was infected, in which case I'd have to take immediate action, whatever that may be. 3. She might not have Ebola at all. In that case, if I went ahead and arranged for transport from Cairo, I would feel ridiculous. After all, I reasoned, since plasma was the only treatment available, as questionable as it was, I wouldn't be any better off incubating in the U.S. than I was here in the Sudan. In any event, there wouldn't be enough time for me to return to the States before I took sick. The incubation period of Ebola is, at most, only a few days after having been exposed the way I was. Then I had to consider another question. If I stayed, and I did have Ebola, would I be putting anyone else's life at risk? In the early stages of the disease, it is not easily transmissible unless someone is exposed to infected blood. That settled it. I would stay and ride it out. That evening, Roy set up a line and gave me the plasma. We washed this down with well over half a bottle of whiskey. I like to think that the alcohol might have had some therapeutic effect. If this was a fantasy, at least I took some consolation from it. The bottle empty, there was nothing else for me to do but go to the rest house to my cot and paper-thin mattress. From that point on, I kept careful watch of that poor old lady, looking in on her at least twice a day, checking her vital signs and drawing her blood to see if she developed antibodies. I slept fitfully when I slept at all. Though I went about with my normal routine, she was constantly on my mind. Whatever happened to her was likely to happen to me. Her fate had become my own.